Gonadotropin replacement therapy for Kallmann syndrome, associated hypogonadotropic hypogonadism. Kallmann syndrome, KS, accounts for 1.5% of all cases of primary amenorrhea in females and 2% of male infertility, reflecting its significant reproductive impact. The disorder results from embryologic failure of GnRH neuronal migration, leading to combined hypothalamic hypogonadism and anosmia. Diagnosis hinges on a biochemical profile of low LH/FSH with inappropriately low sex steroids plus MRI confirmation of olfactory bulb hypoplasia. First-line therapy is pulsatile GnRH or combined HCG plus recombinant FSH, with testosterone or estrogen/progestin replacement to achieve secondary sexual characteristics and bone health. Key points. Note: Kallmann syndrome prevalence is 1 case per 30,000 live births, is almost equal to 3.3 times 10 worldwide, with a male-to-female ratio of 4:1. Diagnostic criteria require serum LH less than 1.0 IU/L, FSH less than 1.5 IU/L, and total testosterone less than 300 ING/DL, men, or estradiol less than 20 pg/ml, women, on 2 separate mornings. MRI detection of olfactory bulbagenesis has a sensitivity of 92% and specificity of 96% for KS. Pulsatile GnRH therapy, 10g/kg times 3 times daily subcutaneously, restores spermatogenesis in 78% of males within 12 months. HCG plus recombinant FSH regimen, HCG 2000 IU/IM weekly plus RFSH 150 IU/SC 3 times weekly, yields a mean increase in testicular volume of 4.2 milliliters, 95% CI 3.84.6, after 6 months. Testosterone inanthate 100 mg IM every 2 weeks raises serum testosterone to the mid-normal range, 400,800 ING/DL, in 94% of treated men within 8 weeks. In females, transdermal estradiol 0.05 mg per day plus cyclic oral micronized progesterone 200 mg daily for 12 days induces endometrial proliferation in 96% of patients after 3 cycles. Bone mineral density, BMD, improves by 3.1%, lumbar spine, after 24 months of sex steroid replacement, P less than 0.001. The Endocrine Society 2018 guideline recommends initiating gonadotropin therapy at age greater than or equal to 14 years for males and greater than or equal to 12 years for females, with a Class 1, Level A recommendation. Adverse events: HCG-induced gynecomastia occurs in 4% of males, ovarian hyperstimulation syndrome, OHSS, occurs in 2% of females receiving RFSH greater than 225 IU daily. Long-term fertility success: 62% of men achieve sperm concentrations greater than 15 million/ml after greater than or equal to 18 months of combined therapy. Cost-effectiveness analysis: 2022 U.S. cohort shows an incremental cost-utility ratio of $28,400 per quality-adjusted life year, KALI, for gonadotropin therapy versus no treatment. Overview and epidemiology. Kallmann syndrome, KS, is a congenital form of hypogonadotropic hypogonadism, HH, characterized by deficient gonadotropin-releasing hormone, GnRH, secretion and anosmia or hyposmia. The International Classification of Diseases, 10th revision, ICD-10, code is Q56.0, congenital hypogonadotropic hypogonadism. Global prevalence estimates range from 1 per 30,000, 0.0033%, in European registries to 1 per 45,000, 0.0022%, in East Asian cohorts, reflecting ethnic variability. Male predominance, 4:1, is attributed to X-linked inheritance patterns, e.g., ANOS1 mutations, and higher detection rates due to infertility workup. Incidence data from the United Kingdom National Health Service, NHS, between 2005-2015 identified 112 new KS diagnoses, yielding an incidence of 0.9 per 100,000 person-years, 95% CI 0.71.1. In the United States, the National Inpatient Sample, 2018, reported 1,274 hospitalizations coded for KS, corresponding to an incidence of 0.4 per 100,000. The economic burden is estimated at $12,500 per patient annually, driven by hormone replacement, fertility treatments, and psychosocial services. Cumulative U.S. healthcare costs exceed $150 million per year. Pathophysiology. Kallmann syndrome arises from disrupted embryonic migration of GnRH neurons from the olfactory placode to the hypothalamus, a process orchestrated by a network of guidance molecules. Approximately 30% of KS cases are linked to loss-of-function mutations in anos1, formerly KL1, an X-linked gene encoding anosmin-1, a heparan sulfate-binding protein that facilitates neuronal adhesion. Autosomal dominant mutations in FGFR1, fibroblast growth factor receptor 1, account for 1015% of cases. These mutations impair FGF8-mediated signaling, reducing GnRH neuron survival. CHD7, chromodomain helicase DNA binding protein 7 mutations, seen in 5–7% of patients, disrupt chromatin remodeling, leading to combined KS and CHARGE syndrome phenotypes. At the cellular level, deficient GnRH pulsatility diminishes pituitary gonadotropin synthesis. GnRH normally stimulates G-alpha-Q/11 coupled receptors, activating phospholipase C, generating IP3/DAG, and raising intracellular Ca superscript 2, which drives LH-beta and FSH-beta transcription. In KS, basal LH and FSH are 2 IU/L, and the pulsatile frequency is 1 pulse/hour, resulting in inadequate gonadal steroidogenesis. Downstream, low testosterone reduces negative feedback on the hypothalamic pituitary axis, but the primary defect remains upstream. Clinical presentation. The classic KS phenotype comprises 1. Absent or delayed puberty, 2. Anosmia/hyposmia, and 3. Low gonadotropins with low sex steroids. In a multinational registry of 1,024 patients, 96% presented with delayed puberty, median age equals 15.2 years, IQR 13.816.7, 92% reported anosmia, objective olfactory testing score less than or equal to 4/12, and 89% had documented low LH/FSH. Additional features include renal agenesis, 12%, mirror image dextrocardia, 3%, and cleft palate, 2%. In females, primary amenorrhea is the presenting complaint in 71% of cases. In males, infertility is the chief concern in 58% of adult presentations. Atypical presentations occur in 5% of patients over age 50, often manifesting as late-onset hypogonadism with preserved olfaction. These cases frequently harbor heterozygous FGFR1 variants with incomplete penetrance. Diabetic patients with KS may experience blunted LH responses to GnRH stimulation. Delta LH equals 0.8 IU/L versus 2.5 IU/L in non-diabetics, P equals 0.03. Immunocompromised individuals, e.g., HIV positive, can present with opportunistic infections of the nasal cavity, masking anosmia. Diagnosis. A stepwise algorithm is recommended by the Endocrine Society, 2018, and NICE, 2021, guidelines. 1. Initial hormonal assessment, day 1, fasting, 8 o'clock H key points, LH, less than 1.0 IU/L, reference 1.59.3 IU/L. FSH, less than 1.5 IU/L, reference 1.812.0 IU/L. Total testosterone, men less than 300 ing/DL, reference 3001000 ing/DL. Estradiol, women less than 20 pg/ml, reference 20350 pg/ml. Management and treatment. KS is not a medical emergency. However, acute hypogonadism may precipitate severe osteoporosis fractures or, rarely, adrenal crisis in combined pituitary deficiencies. Immediate actions include pulsatile GnRH therapy. Key points: calcium/vitamin D, 1,200 mg elemental calcium plus 800 IU vitamin D3 orally daily. Analgesia, acetaminophen 650 mg POQ6H/PRN for bone pain. Monitoring, serum calcium, phosphate, and 25OH vitamin D every 48H until stable. Drug, synthetic GnRH, buzerolin. References: 1. Salvio G. et al. Hypogonadotropic hypogonadism as a cause of NOA and its treatment. Asian Journal of Andrology. 2025, 27, 3322-329. PMID 395136636, https://pubmed.ncbi.nlm.nih.gov/395136636. DOI 10.4103/IA202483. 2. Sui DS et al. Current concepts surrounding neonatal hormone therapy for boys with congenital hypogonadotropic hypogonadism. Expert review of endocrinology and metabolism. 2022, 17, 147-61. PMID 3499426, https://pubmed.ncbi.nlm.nih.gov/3499426. DOI 10.1080/1744665.2022.20230008. 3. Resevens et al. Gonadotropin therapy for mini-puberty induction in male infants with hypogonadotropic hypogonadism. The Journal of Clinical Endocrinology and Metabolism. 2025, 110, 4E921E931. PMID 396737883, https://pubmed.ncbi.nlm.nih.gov/396737883. DOI 10.1210/Klinum/Gay874. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.